just a minute to get started. There we go. Now we've got it. Okay, so my name is Helen Hockey. I am the Executive Director for the Pennsylvania Coalition for Oral Health, which is a statewide nonprofit education and advocacy organization that focuses on improving oral health for all Pennsylvanians. I'm joined today by Dr. Sean Boyens, and I'll ask him to introduce himself at this time.
Hello, folks. I am Sean Boyens. I am the Vice President of Government Growth and Innovation at Avisis, and look forward to spending the next hour with you all.
Great. Thank you so much. It's been a real pleasure working with Dr. Boyens on this project, and we're really excited to share some of that excitement and interesting information with our audience today. So as we progress through the slides, please feel free to type any questions you have at any point into the Q&A box. We may be able to grab some of those throughout the presentation, and if not, we should be able to grab some at the end. Next slide, please. So our coalition works as a direct contractor under the Pennsylvania Department of Health and their oral health program. And we were fortunate that Pennsylvania was awarded a 4-year grant in 2018 that focused on dental workforce by the Health Resources and Services Administration, or HRSA. So one of the projects we took on was to analyze our current workforce numbers and make sure that we were able to share that information with our stakeholders. And just as a side note, in just a few months ago, we were also awarded the next round of that similar funding through the HRSA Oral Health Workforce Grants. So we look forward to spending the next 4 years focusing on some of the solutions that we're going to talk about later in the presentation. Next slide, please. So we have to, of course, give a really big thank you to everyone that you can see here on the slide that has contributed to this work, both in front and behind the scenes. We're really appreciative of all the time from so many of these folks. And, you know, they've lent us their expertise, and we hope that we have made them proud of what we're going to share with you today, and hope that that really starts to spark some interest from a lot of different folks on pursuing some of the solutions we're going to talk about. So next slide, please. So Pennsylvania is somewhat unique, and I know we have some folks on that aren't necessarily from Pennsylvania. So I am going to do a little bit of level setting on this, that we collect and we publicly share a lot of data from the State Board of Dentistry. So we track this info pretty carefully at PCOH, and we request different lists and information sheets annually, sometimes biennially. And our partners at the Department of Health work with a lot of those data that are collected from the Licensure survey as well, that our dental providers complete. So we kind of combine some of that information with current licensure lists from the State Board of Dentistry, and started to work towards putting these reports together. We knew anecdotally that people were having trouble finding providers. Dentists were struggling to find staff, and we wanted to take a deeper dive into what the real numbers were. So our first part of these reports, which was a part 1, was released in July and evaluated our high-level numbers of providers and how they've changed over the last 7 years. We're going to mention a few of those data points on this webinar, so don't worry if you missed that. But for the second report, we wanted to focus on a more qualitative approach and really look at the information that's collected from each provider about their attitudes towards dentistry, their work practices, all of the things that affect all of us. So as we dive into the data, I'm going to turn it over to Dr. Boyens to provide a little bit more background on how the analysis was run and the work that went into preparing the information we're sharing today. So next slide, please.
And thanks, Helen. So there's basically 4 main areas, data sets that we utilize to complete this part 2 report. One, as Helen stated, was the Bureau of Professional Occupational Affairs Biennial Pennsylvania Dental Licensure Survey. So every time you will go in to renew your license, you fill out this survey with all of the questions that gets put into a centralized data set, and we're able to evaluate what those responses were. The years that we looked at were 2015, 2019, and 2021. You can see the response rates, which are actually quite high. We still cannot figure out how some people are not completing the surveys, but I guess there's still enough percentages you can see, especially in 21, where we're up over 98% for hygienists and 93%, which gives us enough to feel that we have a representative sample for Pennsylvania. PCOH launched an online survey to evaluate public health dental hygiene practitioners and what their practices were, what their attitudes and awareness was. And we'll get into that a little bit. It's included fully in the report. We had about a 20% response rate, 173, which is representative of 20% of the workforce. So we feel we have a pretty good sample there. We have the secret shopper sites during Q3 of 2022, and we'll talk a little bit about the secret shopper analysis, where phone calls were made to, as you can see, over 1,000 dental practices to understand where their wait times were at, also understand the type of insurance they were taking, operational hours, et cetera, et cetera. And then last was a list of all licensees and certification holders that we received through the Pennsylvania Department of State. And these were the license numbers, the pool that we received from the state. We updated the Part 1 report with this data from Q2 of 2022. And this is the most boring slide we have, I promise, once we get past this, but wanted to make sure you guys knew where our sample sizes were at. And I'll turn it back over to Helen.
Thank you so much. Next slide, please. So diving in, right? Let's look at these numbers. Let's see where we're at. And we figured we'd start with a real nice busy slide that gives you so much information. When we look at all of these different columns, you know, what we are seeing here is that we're continuing to struggle with that return to our pre-pandemic workforce levels. Our dentists are working less hours per week. We're seeing more of them in urban areas, you know, and less in rural areas. And, you know, our state does continue, as you can see across sort of the last few columns there, we're seeing an increase in things like local anesthesia permits for hygienists, the PHDH certifications, and our EFTA certifications, our expanded function dental assistants. But what's happening is we're seeing those numbers go up. We're seeing things are doing well there, but those individual professionals are not being used to the top of their licensure. So, you know, which then results in less services for folks. So what I really wanted to point out on this slide, though, when you look at the numbers, the thing that strikes me the most is those first 5 columns to the left. So when we're looking at dentists and hygienists, oftentimes people look at, you know, overall numbers and assume our workforce is adequate because, as you can see, close to 10,000 dentists in the state for 13 million people, we're doing all right. We'll be okay. But one of the things that we don't realize when we compare columns 1 and 2 and columns 4 and 5 is that we see some big differences between those licensed to provide care in Pennsylvania and those that are actually doing it. And so it's something that we have to address a little bit in how we analyze this information. Dr. Boynes and I are actually great examples of this. We both hold State Board of Dentistry licenses in our state, and neither one of us is actively practicing and seeing patients. So I guess we're part of the problem in terms of the numbers and how we reflect them. But we want to make sure we're thinking critically about these numbers and then how they translate into people seeking care. Next slide, please. So we're going to kick off the look inside the numbers with some breakouts here. So you can see a breakout of age, the age groups and sex of the providers in 2021. So Pennsylvania's got a very diverse, really more diverse and more female population of dentists compared to 7 years ago. You know, our percentage has really grown, and we do better than a lot of other states in our diversity. So I think, you know, we're seeing that shift. And as you can see, those differences in the balance of yellow and blue over time, when we look at those age groups, our oldest dentist population age group is definitely the one that is predominantly male. And then we've seen that balance out so that, you know, for the folks from the mid 40s and younger, we're really looking at a close to 50-50 split. So that we see a lot of kind of really expected, very like what we see nationally. I did want to mention a little bit about the age though, because it, I think we've always known that Pennsylvania does tend to have a little bit of an older population. And we don't see, we see that a little bit with our dentists and hygienists as well. So you can see that in our state, the average for dentists, average age is 51.9 years. Average hygienist is 45.7 years. And that is a few years ahead of what our national average looks like. So we do have a slightly older dental provider population. But again, really focusing on how we keep that balance and maintain that while also driving in some of the younger folks into these dental careers, I think is going to be really, really important. So I'm going to turn it back over to Dr. Boyens for the next slide to talk about practices and employees.
So this is a trend that we are continuing to see nationally. And I know the American Dental Association's Health Policy Institute just a couple of weeks ago put out a national report that sort of aligns with what we found, which is that practice ownership is on the decline, employee status is on the increase. The younger you are in your experience of your career, the more likely you are to be an employee. And where we see the average age of practice ownership really moving up in sort of leaps and bounds. And you can see from 2019 to 2021 is where we saw the steepest increase. What this may relate to is a lot of associates as retirements came up. We did see an increase in Pennsylvania of sales of those traditional private practices to those dental service organizations. And so that could be an explanation for that. I think we tend to say, hey, it was COVID and the pandemic, but I think with this, I think it was just the structure of what was happening within the pandemic and where people may be at. And as Helen showed you the previous graph, you could see that 65 and plus is one of the highest populations of dentists that we have. And many of them are nearing retirement. And we'll talk about that a little bit, a couple of slides ahead. Next slide.
Okay, so to give you sort of the cart before the horse here, we're going to give you some of the key takeaways of what the report really discovered. The first is that we're not utilizing our current workforce properly. So as you can see, almost half of our direct access and expanded function practitioners aren't working to the level of their training or scope of practice. So if we're not utilizing them properly, we're not stretching the amount of folks that we can see in dental offices to the best of our ability. Next, we know rural areas of our state are having more trouble than our non-rural areas. So we've seen, providers leaving those areas. We have seen higher levels of dissatisfaction in their positions. And then we don't see some of our, more direct access practitioners and expanded functions dental assistants going to those areas. So, it's not just the total number of providers there, it's also who's there and what that makeup looks like. And then, of course, we've all known that our specialists do tend to lie in the urban centers, and we don't have enough people looking to seek dental careers right now. So we're not going to be replacing those folks that are leaving in the next 5 or 6 years. The third takeaway that we wanted to just mention is looking at our capacity. The capacity of our current, offices are not adequate. So when we completed the secret shopper survey, we noticed that, when we started talking about 40%, only 40% of those sites is having an appointment open in the next month, which is less, it's really about half of what it was just 4 years ago. So again, knowing that we're stretching these appointment times out means people are not able to access dental care, putting more and more strains on the workforce. Next slide, please. Also, a really important finding, our providers are not very happy in their current positions. And as we increase the percentage of younger providers in our state, we're going to start seeing less working hours, which is going to equate to less appointments available for people. So we want to make sure that we're encouraging the folks that are still in the dental profession to stay here as long as they can, which means we have to, of course, make them happy. And then lastly, we're seeing some discrepancies for access based on, things like a person's disability status. As you can see, in 2021, the data from the licensure survey demonstrated that, only 2 out of every 5 dentists are accepting people with disabilities. And so we definitely saw that translate in our secret shopper survey as well. That was definitely the population group that had the hardest time getting an appointment. So definitely that's sort of what we're going to dive into a little bit today. Next slide, please.
Ooh, animations. So as Helen and I were thinking through the webinar today, we didn't want to just throw the recommendations at the end and say, okay, here's all this data and here's what we're recommending. So trying to put the recommendation out there and then give you a little bit of the science behind why that recommendation came forward. The first recommendation, as you see here, is to address training and education. We need to improve the percentage of dental school enrollees that are Pennsylvania residents. We need to increase training locations in rural counties. We need to improve the number and data transparency of graduate programs and residencies. So these are our specialist providers, understanding where they're training, where they may be coming from, and where they're going. And then galvanize around equitable, non-traditional dental training programs that utilize technology and community-based care delivery, making sure that we're thinking across the spectrum of who can and how we can solicit new folks to come into oral health and what that may mean. Next slide.
Okay, so this is one of my favorite data sets. I'm not sure if everyone on the call has a favorite data set, but this is definitely one of mine. When we start talking about this problem and how we're going to fix it. So we know that, as you see here, and I'm not going to read you all the numbers, but when we start talking about where are these dentists going once they leave dental school, where are they practicing? Are they practicing in a shortage area, which is that second to last column from the right side there? Are they going to rural areas? So a lot of this information is collected, for intentions of where they're going. And what we know is that we need to recruit more Pennsylvania residents, specifically Pennsylvania rural residents, to go to dental school and become dentists, right? That's what we would love to see. It really is the best way to ensure we have a chance of them staying in the state, maybe even practicing in their hometowns. And I know, and we get this argument a lot, that many students, leave a rural area, they go off to the city, and they decide not to go back, right? That's a very normal thing that happens. But I always use the example that if you've got, 4 students from Tioga County up in the northern tier that all graduate from dental school, you've got at least a chance that 1 or 2 of them might end up practicing in Tioga County. But if you take those same 4 students and they're from Philly or Pittsburgh, what are those chances of them going to Tioga County to practice? We don't see that. So we look at these numbers and we decide, okay, well, if we really need more dentists in certain areas, we've got to possibly target some of those areas. And then the last 2 columns on this slide demonstrate how few of these graduates actually end up, they express this intention, and do they end up actually practicing in an underserved area or rural community. So just for, again, more level setting in what our state looks like right now, we've got about 150 dental health professional shortage areas in the state. So that column that starts with the 8.2, we have 150 of them. In order to meet the needs of those 150 shortage areas, HRSA estimates that we need 337 dentists to go to those spots. So as you can see, we're not putting out anywhere near 337 dentists into those dental health professional shortage areas. So according to this chart, it would take us about 14 years to meet that goal, provided that nothing else changes in the meantime. So very much a problem in that we need to get some of our graduating dentists to start thinking about practicing in these dental shortage areas and in rural areas. Next slide, please. That's why it was my favorite data set, I have to say.
I have to think about what my favorite data set is. I've never given it much thought, but I imagine I do have my favorites. I think this might be one of mine, at least a data point. So what this slide is actually from the part 1 report, but we found the analysis so strong that we wanted to bring it back one more time, because what you're seeing here is sort of an overlay of where we have a density of dental healthcare workers. So these are your dental hygienists, dental assistants, and dentists, and where training programs are located. And there is a statistical significance, whether a county is rural or not, that you have a greater density of providers and of care access, or at least care sites, when you have training programs located within those counties. And so it really becomes important to think through how we may want to structure in the future, knowing that if there is a workforce available and there is a way to get good new personnel constantly coming in, then it does create better density in each county that has that sort of training structure. And you can see we definitely do not have training programs in places that we feel would benefit the most, especially within those rural areas. And remember, it's not just about dentists, it's also about dental hygienists and dental assistants. You have to have a workforce if you're going to open a business. And if you want to grow that business, you need to continue to have additional workforce to do that. And so having these training programs in place allows for that to happen and allows for more economic investment overall. This particular slide, I think, sort of paves the way. I know there's other states where this may not be the case, but Pennsylvania is one of those states where we can look back and see those correlations. So I do think it's something that we have to consider here at home. Next slide. There's some ways to move training and getting personnel in. We wanted to include this slide because we're basically coming through and saying, hey, there's nobody out there, and wanted to have some sort of solutions, or at least provide where there is information if you're a care organization or a dentist that joined this webinar. And so these are sort of the programs that a lot of people point to. There's one from the California Primary Care Association, which talks about growing a dental assistant pipeline. You have the National Network for Oral Health Access, which is promising practice and creating staffing. And while these are safety net associated programs and frameworks, they work just as well within any type of practice activity, really saying, here's kind of a mechanism of how you can bring individuals in that may not have previous training and work with them to get them up to a level where they'll be able to impact patient care. One of the most quoted books into all these programs is Essentials of Dental Assisting by Debbie Robinson. So I thought I would include that book within this slide, just in case you were looking for what's the bee's knees and how we train dental assistants these days. Next slide.
Bee's knees. I love it. So our second recommendation here, and we touched on this a little bit, so no surprise, but we really need to make sure we're utilizing all of our providers and professionals to the top of their certifications and their licenses. So, and then figuring out how we're going to pay them to do so, of course, is an important part of that. Looking at, how many of our non-dentists are out there seeking to do more, having advanced certifications, using all the permits that they can get, and then, of course, funding this. So when we talk about different care models and payment models and service delivery, we're talking teledentistry, we're talking value-based care, we're talking medical dental integration, all these different ways that might be sort of outside the scope of what we traditionally call dental services. Are really going to kind of have to be all hands on deck. And then, lastly, looking at how people feel supported to treat people with disabilities. So whether it's financially, whether it's their comfort level in the actual practice, whether it's they have the system in place just in their brick and mortar that supports that. We just want to make sure that we're seeing that improve, because we really can't allow one population in our state to have substandard access to dental care. And that's really what we're looking at right now. Next slide, please. So apologies to everyone for all of the info we crammed on this slide, but we just had to do it. We knew you needed to see all of this. And we're going to talk for a minute about our expanded functions dental assistants, the EFDAs. You know, these professionals work under the direct supervision of a dentist in our state. They can place fillings, provide fluoride and sealant services, and really can be a difference maker in an office to stretch other providers, which then allows more patients to be seen. In Pennsylvania, we've got sort of a disproportionate amount of EFDAs in our like southern non-rural areas. So we see that the highest concentrations there, and we've got to figure out how we get more of those EFDAs to be utilized in the lighter green areas that you see across the top of the state. So you can see, you know, in terms of the graphs on the left, looking at our urban versus rural numbers, a pretty big discrepancy there. And also, again, looking at the way that these numbers have grown over time, we're seeing, and what I think is more and more dental assistants wanting to kind of move on and become EFDAs. And we're seeing dental hygienists want to get an EFDA certification so that they can do more services. So we want to make sure we're taking advantage of that, and we're placing these EFDAs in all the places that we need them.
And the only thing I would add here is, if we want to increase the number, really starting to think through how we can tie into vocational programs and make a continuum of education and training for dental assistants, so they understand that there's upward mobility and a way to advance within a career. And if you look at the way the map is, you tying into those vocational schools that are starting to, or have the ability to bring dental assistants along. We have the University of Pittsburgh Medical Center program partnering with Pittsburgh Public Schools. I know Temple was doing something similar, a few other organizations, starting to think through how can we tie into a continuum care for a lifelong learner. Because a big reason why we've lost a lot of dental assistants and dental hygienists has been an inability to have mobility, upward mobility in their process of their career. Next slide.
There we go. And so we mentioned the survey of the public health dental hygiene practitioners, our direct access dental hygienists that work in public health settings. And again, you know, we were able to get a decent response for the total number of certified PHDHPs in the state. So we asked them a lot of different questions. And what we found was, you know, the majority of the time for PHDHPs is really spent in clinical care. They are doing some public health, some outreach, and some admin tasks and management. But what we're noticing here is that 59% are saying, I'm not working to the highest level that I could be. I could have more responsibility. I could do more. Again, we're seeing a disproportionate ratio of them located in urban areas as opposed to rural areas. And often many of them are working in private practice because they're not able to utilize their certification and work in public health. So that's something that we discovered. There's a lot of details in the report about that survey, but wanted to draw your attention to the table here. This was a question we asked open-ended at the end just to say, hey, we want to hear from you. What are you happy about being a PHDHP? Like, what makes you happy? And then what frustrates you? What makes it really difficult for you to, you know, feel like you're using all of your capabilities? So, you know, you can see what the numbers reflect there. You know, nothing as a big surprise, but I think that, you know, definitely there are, we have dental professionals here that are clamoring to do more, and we should probably fully utilize them to make sure we can see as many patients as possible. Next slide, please.
So for this slide, as we talked about, we continue to see some disparities with individuals with intellectual and developmental disabilities. This is showing you a breakdown of per population dentists that signify that they see this particular population. It's about 40.2% that say at least self-report accepting the individuals with IDD. When you look at the HIPSA areas, obviously the gray means 0, but if you look at our dental HIPSA areas and you also look at our rural areas, that's where you see even more discrepancy. And being able to see this population being able to get care. Just point out at the bottom, because we're doing this as a per population count, the darker the blue, the wider the frame is. So that means for every one dentist, there's more population. So the lighter blue means there's lower numbers. But when we look, it's well below where the national benchmarks say we should be. So every county actually has a disparity that's going on, regardless of whether it's Allegheny or any of Montgomery or Philadelphia, all having issues with getting access to care for this particular population. Next slide. And we were able to demonstrate that with the secret shopper. This is sort of a sneak peek. We're going to get a little bit more into the nitty gritty with the secret shopper structure here a couple slides ahead, but because it was relevant to this population, wanted to include it here. Just as a reminder, this is 1,212 dental sites evenly distributed across the state. There are 4 scenarios that we went with: child with Medicaid, child with IDD, having Medicaid and commercial insurance, caregiver, a commercial adult, and then self-pay adult and child. As you can see, when we looked at the not seeing new patients site, see a little bit of discrimination coming through, not claiming that it's on purpose, just saying the disparity is there between those with Medicaid and IDD versus the commercial adult and the self-pay. The other piece that was interesting with individuals IDD, not only were there less ability to find a patient, a dentist accepting a new patient, but there was a lot of referrals. There was a lot of, we can't see you here because we don't have the equipment or ability, and referring out. So for that population, if you look at available providers, they're only going to have half of what's available to be able to find a dental appointment, which significantly altered their time to care and care access. Next slide.
Okay, so when we, moving on to our third recommendation, looking at how we get people to love their careers and stay in them for a long time, is really looking at how we get the build-up for value. And I'm not going to read all of these, but we really wanted to deal with the financial side. You know, from an employment standpoint, we're going to share some numbers that may surprise you with how Pennsylvania compares with other states, and how we really have to make sure that we're competitively taking care of our dental personnel from a financial side, and give them more opportunities to be more fulfilled in their work. Next slide, please. So as you can see, we have some comparisons here. Pennsylvania, as I mentioned, is not doing well in our compensation to the dental field as compared to the states around us. A little bit more clustering, I think, for dental hygienists, where we see a little bit of a closer kind of knot of numbers, but we're still in 44th position in the country here. So it's pretty shameful, I think, for a state that really does, I think, does really well in so many ways. We're the 5th most populous state in the nation. We should be doing better for our dental professionals. So, you know, when we look at the center number there with our dental assistants, I will say that this includes EFTAs. And so some states that may not have an expanded function dental assistant piece, you might see a little bit of a discrepancy there. I think that is the reason that we end up in that number 22 spot instead of down into the 40s like we are for the other professions, is that, you know, if you're comparing a state with expanded function assistance to one without, you're going to see some difference there. And then lastly, I think when we talk about the general dentist and those annual salaries, I don't know about you guys, but there's like more than $100,000 difference between the first spot and us. So if we want dentists to want to stay in Pennsylvania and practice in Pennsylvania, we've got to do things that do better for them and get them higher up in that rankings. So definitely a big problem there. Next slide, please.
So on this slide is just really talking about the need for advancement in professional development. there was a regular pattern from 2015 that our dental hygiene workforce has become more educated, have become it's more likely that they would have an advanced degree. I think what's interesting is if you look at the degrees that they can advance on within dentistry, they're more likely to go to a degree that's outside of necessarily the clinical scope, although it can be related or complementary. But for the most part, we do see some attrition as dental hygienists become more educated, especially if they have a degree outside of the clinical aspects of dental hygiene, that they do tend to leave the workforce to go work in another environment.
And I would certainly add here, I think that, we need to build what, whether you call it a career ladder or you call it a pathway, we need something better than what we've got so that our current professionals can continue to be utilized. If we look at the medical profession and we look at all the steps to nursing and how we help people kind of progress through that process, we don't see that in dentistry. So we want to make sure we're giving people the support they need to progress through that side. Next slide, please. So fourth recommendation, rural. Definitely a sort of a blaring light of problem when we start looking at these things. So what can we do that will bring in recommendations to address things that will benefit rural areas most? And again, so we'll dive into a little bit of this. The report goes into a lot of detail, but a lot of it comes down to just straight numbers and distribution. Next slide, please.
Speaking of numbers and distribution, thank you, Helen. A lot of pictures on this slide as well. I think you can see that I think when you look at all four of these next to each other, you can see glaringly that we do have some rural disparity issues. So on your upper left, this is our per 100,000 population ratio, which is usually the national accepted standard of how we look at workforce for dentists. The ADA's national average is 61 dentists per 100,000 population. Pennsylvania's average in the rural areas still lower than that. We're 56.7. So overall, the state does have lower than average per population ratios. We'd like to get those up, but in the rural areas, it's 40.8. So almost 20, actually more than 20 points below where the national average sits. Your upper right, that's the number of dental hygienists with local anesthesia administration permits by county. As you can see, there's a preponderance of permit holders for local anesthesia. When we look at the science behind who does local anesthesia the most, it's usually hygienists doing scaling and root planing, usually scaling and root planing associated with periodontal disease and diabetes. And so when we know we have in Pennsylvania some rural health problems around those systemic illnesses, we would certainly like to see more ability in the rural areas for local anesthetic administration. Your lower right is county level data, the number of individuals treating IDD population, and we talked about that. And on your lower left, that's individuals with an unrestricted permit. Those are individuals that can provide general anesthesia or on the dental side or licensed on the dental side to do so. Preponderance in the urban areas, and most of these individuals are oral surgeons providing sedation anesthesia, not squarely to the IDD population. So it's probably even more stark with our ability to get that anesthesia access that we want and need for a certain portion of this population. Next slide.
Okay, so our recommendation 5, we hear when we start talking workforce and how do we get more providers out there, we talk about loan repayment. Everything is loan repayment, loan repayment. So we need to address loan repayment. We know that that is one solution to some of the issues we have. So we're going to talk a little bit about what that looks like. If we can go to the next slide, please. So in our state, we justify our dental health professional shortage areas. Those are the areas that we send people to, that we issue loan repayment programs through. Our Health Resources and Services Administration designates our dental health professional shortage areas as those that score from a 1 to 26 on a scale they use. And, you know, some of those points come from population to provider ratio. So we were just talking about that 60 to 100,000 number. Also looking at how many of the folks in a certain region or area are living at 100% or below of the federal poverty level. And then some points for distance to the nearest care provider. They do allow points for that. And in dental, they also add an additional, you know, yes or no point for if an area has community water fluoridation available. So, you know, out of these 26 points, we look at the areas around the state, they assign scores. And if you choose to practice in one of those areas with the higher scores, then you qualify for loan forgiveness. So, you know, I think, Dr. Boyens, did you want to add anything about that targeted approach thought?
Yeah, just you wanted to point out the county locations, and really maybe we need to think about being much more specific and targeted based on zip code of where the next year's award should go, making sure that we have a good distribution for the dollars that are in place. And then the other thing that we're really weak on from a data standpoint is whether or not there's retention after these awards go out. And so finding some way to shore up that those retention numbers so that we can get very specific into what counties we may be able to have higher retention, and figuring out how that may or may not affect scoring.
Absolutely. Yeah. And there, you know, we're sharing the primary care loan repayment program here, the numbers from that. There are other sources of loan repayment in addition to this program that Pennsylvania providers can apply for, National Health Services Corps. So we need to do a better job of sharing this info. And I think that would help us a lot. Next slide, please.
The other piece that came out from this analysis is that we have high levels of burnout, and that there's an increase in dissatisfaction. And so there's really not a lot of data. We started, fortunately, the PCOH is starting to do a lot more surveys, and we're asking burnout questions, we're asking satisfaction questions, but we still need a lot more information so we can figure a better way to support the population overall. Dentists reported that the ability to connect with patients and autonomy and decision-making were the #1 drivers of their satisfaction, whereas #1 drivers of dissatisfaction tend to relate to the regulatory and administrative overburden and losing that work-life balance. And so, as we talked about earlier, that's sort of resulting in dentists working less hours. Next slide. One of the other things that leads to pretty big burnout, and why we placed it here, is being at capacity and having nothing left to give. I'm a Star Trek fan, so when we finished this project up, the image of Scotty telling the captain that she's given her all she's got, captain, and there ain't any more. I mean, I think we're even past that point, but that is the image that really came up through the Secret Shopper project. And the one piece that didn't get captured in this analysis, as somebody who did, I made phone calls myself. We had a full team of wonderful people who helped make these phone calls, but there was almost a painful exchange with the front office because they really want to help, and you could hear some exasperation. So here's the methodology that we moved. There was 4 scenarios, one being the IDD population. The thought may be that that's why we have a longer period of days, and that may have increased because we were oversampling the population that's hardest to get in. But we didn't find that the ranges in days for them to get in were similar regardless of the scenario that we gave. What they ended up being affected by in that scenario was a lot of dentists saying they weren't accepting new patients at a higher level than the others. Several that referred out saying that they didn't, and then also that they would do a prophy or try to do an exam, but if any cavities were found, they would be referred elsewhere. And it was 1,212 sites. Next slide. Just to kind of go through the results, as you can see, the average, the number of not accepting new patients is 15.5%. You can compare and check the report out if you want to see the differences. Obviously, as you get to the right and into the more safety net realm, Our safety net is really getting pushed to capacity. So it's always a trickle down effect. If we see longer wait times here, it affects the safety net at a higher level. It's 54.6 days to first available appointment. We have 39.6% of sites within the first 30 days. That's a significant decrease from a previous report that was done by Eric Stoner out of Allegheny County, which found about 76 to 80% of sites could get you in within that first 30 days. Now we're down to below 40. We did ask in the secret shopper analysis if we had a cavity or if the child had a cavity, how long would it take to get in for that appointment? That was about 35.6. So right now your total wait time, at least in the summer, and I do venture to say that this is probably a little bit less, but I don't think more than 15%. Total wait time for treatment of disease is about 90 days. From a Medicaid standpoint, the goal is to try to get someone in within a 15-day period. So as you can see, our system is pretty well stretched across the board, with our safety net kind of carrying the biggest burden for capacity right now and probably trying to breathe as best they can. Next slide. Just to kind of continue here, a little bit more of the results. When we look overall, have about almost 30% of individuals that are accepting Medicaid and Medicare. These numbers are less than in previous reports, so we are seeing a decrease in the number of providers that are opting into Medicaid. We see 16.4% that do not accept any commercial insurance. That's an increase. We did see, as we were making calls, and this came up in the notes, a lot of dentists are starting to offer in-house plans and even opting out of the PPO contracts. Online scheduling, we saw an increase from previous reports of that, 9.7. And this isn't you request for an appointment. This is where you can actually make an appointment on a phone or on a laptop directly linked to your calendar. And this is the first time that there was analysis on Google rating scores. So the way that the secret shopper structure went is we did dentist near me on Google, which is the #1 way that people find their dentist. And so because we were using Google as a strategy, we went ahead and wrote the Google rating scores down. The one thing I'll point out is the ratings for the FQHCs and other nonprofits, maybe for an entire health system, we could not parse out a lot of times where dental may be separated. Next slide.
Excellent point there. So the one thing that, when we looked at those days of dental visits, and we talked a little bit about this, I thought it was an important thing to show when we look at the blue bars here. We've got about an average wait of about 2.5 months for that first appointment in rural areas, and then about a little over half of that in urban areas. So there's a pretty significant change there. But one of the things that doesn't demonstrate itself on this slide, but was discovered during the process, is that our rural offices were more likely to say yes to putting someone on a waiting list. And so you'll have a longer time. You've got, you're on that waiting list, whereas an urban office would just say, we're not accepting new patients. So, that actually maybe is protecting their current patients a little better, maybe holding, that system in place so that, they're able to do more for the patients that are already on their books. And it could account for some of the difference in the waiting list. I'm not really sure in my mind what system works better there, to be honest. But either way, we know that these practices are getting so much demand for appointments, which is going to have that effect on our dental providers and their work satisfaction. Next slide, please. And I know Dr. Boynes alluded to this a little bit, some of the dissatisfaction and satisfaction ratings that the dentist provided on the 2019 licensure survey. As you can see, the providers love the fact that they have these relationships with patients. Everyone thinks that's wonderful. And I think dental offices have long been known for that. We really do. It comes across as listening more and caring more. You have longer appointments, and those relationships do get built, and they're very important. But when we start looking at those reasons for dissatisfaction, we're working too much. We're dealing with all the money and the finances and the business ownership. And then staff, staff relationships, including turnover, are going to be some issues there. Next slide, please. We also looked at burnout in our PHDHP survey. So looking at our direct access hygienists to see where we're at. We did break down all PHDHPs versus those that reported working in an FQHC because FQHCs are the when employment place for where a PHDHP is going to be worked and be utilized as a PHDHP. So when we look at those, when we start to see that yellow and the light blue color, that is a lot of burnout, right? So that's where we see the major issues. When we look at that dark blue color, those are the ones that are doing great, like they have no problems. That's a very small wedge in both of those circles. And so where we're really seeing it is that gray area. So I'm definitely burning out and, I'm having some physical and emotional exhaustion. Look at the gray area for the FQHCs. That's huge. And we combine that with a little bits of burnout, we're going to lose them. We're going to lose them all, and then our safety net will completely crumble. So we've got to make sure we're doing things that are supporting and preventing against that burnout. Next slide, please.
So here are some important data points, just because I think it demonstrates that Pennsylvania probably has to think more long-term than maybe other states, and we have to be committed to a longer-term plan. And it's because when asked how many years you think you're going to remain in the field, we're going to lose about 1/3 of our dentist population within the next 6 years. We're also anticipating losing almost 24% of our dental hygienists. And so unfortunately, when you break this down, and you'll see this in the report, a lot of these individuals tend to be located in those rural areas where we're already hurting and not adequately replacing those personnel to serve the population. Next slide. When the individuals were asked on the survey, those that were planning to leave in 6 years, what the reasons were, you can see number one's retirement, and that corresponds with the first slide, one of the first slides we showed you, where there's a huge population, 65 years plus, sitting out there. It's the highest population we have. So the highest population of dentists in Pennsylvania by age group is 65 years of age and older, and it's very significant. So these retirements should be a sort of bullhorn. And I know we've, for a very long time, talked about, hey, we have a real problem, we have a real problem. I think the effects we're seeing now, which is now extended wait times, we don't have access to specialty care, all the things that are starting to impact our safety net, it's related to the fact we're not replacing these dentists adequately, and we have a maldistribution. The other piece I'll point out really quick is that sort of bright blue line, which is physical demands. So looking at evaluations just for this webinar of disability reports, dentists tend to be at the top of those lists with dental hygienists. Tends to be a lot of issues with back issues, physical issues that do not allow them to continue the job. Average age where we start to see that impact is around 45.2. This is very similar data points to coal miners. So I just wanted to point that out, that this is a labor-oriented profession, and we do lose a great amount of individuals to that. So we don't know if we dedicate beyond ergonomics into how we can decrease those disability numbers. Next slide.
I think it's important too, as we wrap up here and folks have a chance to put some questions in the Q&A, to point out that those numbers in terms of that 30+% of dentists leaving in the next 6 years and 20+% of hygienists leaving in the next 6 years, those numbers are 2021 numbers, which we knew that was all happening a long time ago, but we saw a decrease, and you can read more about that in part 1. We saw a decrease in our provider numbers from 2019 to 2021 already. We thought we kind of pulled out all the retirements. We really thought that, once COVID hit and everyone else, and we knew that a lot of folks who maybe were holding on decided, all right, I'm not going to renew my license. I'm done. I'm out. I'm retired. So getting those high numbers of the 30% plus and 20% plus on a 2021 survey is even more alarming, because we thought we already lost them all due to the pandemic. Turns out we didn't. The ones that stuck around are still planning to leave, and we're going to still see the effects of that problem, over the next few years. So we really, I think we've got to start talking about it, and we've got to understand that we can't just increase the number of dentists in a week or two. It's going to take a decade. You know, if we want to get our numbers to come up, it's going to take a decade. So the problems we're facing now, knowing that we're expecting these to get a little bit worse over time, are not going to be ones we can solve very quickly. So really exploring, you know, alternative methods and how we can get care to folks and get them more preventive services, education services, any way that we can help navigate them to care over the coming decade is going to be really, really helpful. And I can't believe I'm going to say this, and thank you, Dr. Polk, for your comments here. And it looks like, you know, a lot of folks are offering comments in terms of, you know, saying that it's great information. No questions yet. I cannot believe I'm saying that. Hopefully you all have had a chance to possibly look at the report. Definitely keep in touch with us. We know that we're going to be using this report over the next few years to guide some of the work that we're doing as a state and within the Oral Health Coalition. I would also point out that for folks that are familiar, we do have a report coming out from our Pennsylvania General Assembly next week through the Legislative Budget and Finance Committee, who are looking at oral health, rural health disparities. And we're expecting to see some direct policy recommendations there. So stay tuned for that. And yes, we will absolutely be sharing the slides. The recording will be shared as well, so that the information can be used, and you guys will all have the link to the report itself to read and digest completely. I'll give everyone one more second here to see if we have any other questions come in. I think that's about it. So with that, if I'm not seeing any others, we'll say thank you guys so much for tuning in today, and thank you, Dr. Boyens, for joining us on this really important discussion and for all of the hard work here. And keep in touch, everyone, and hopefully we can solve some of these issues together. All right. Thank you.